And it is now my pleasure to turn the call over to Jen Farfalla. Jen, please go ahead.
Hi, everyone. This is Jen Farfalla, ASTO's Director of Overdose Surveillance and Prevention. Thanks so much for joining us today for ASTO's OD2A Learning Community session on the rise of stimulant overdoses and harm reduction. This is our agenda for today. We'll have two presenters who I'll introduce in a moment, Sheila Vakharia from the Drug Policy Alliance and Katie B. and Michelle Tilotta, who are working with the Iowa Department of Health on efforts to address methamphetamine overdose in their state. And after these presentations, we'll have a quick Q&A session before closing out our session. And before we get started, we do have two quick poll questions for you all, and these pertain to the structure of our OD2A learning community. First, we started off our learning community with a regional model in that we were planning on having sessions by region to make groups smaller, have more interaction, and zero in on topics that were relevant to that specific region of the country. We've moved now to the current model of having larger OD2A learning community-wide webinars because we recognize there's a lot of uncertainty in health agency capacity. Schedules are uncertain due to the COVID-19 response. So if we have a regional call with 6 jurisdictions and half can't join because of competing priorities, it would make it very tough to have a productive session. So we want to check in with you all to see, do you prefer that we stay in the current model of one larger webinar for the whole learning community, or would you like to see the learning community go back to that regional model in the coming months? So Irena, could you bring up the poll, please?
Yes, and I also have part 2 and with the part 1 question as well. So if you'd like to read that question.
Okay, and the second question we had was around an online discussion forum for this learning community. So ASTO has the capacity to make an online discussion forum for the learning community. You can engage with peers in discussion posts. You can share resources. We can share resources on that forum instead of emailing them out to all of you all and having you dig through your emails. You could have them in this one area. And it would be a place where you could discuss OD2A efforts and challenges too. So the question is, would you all be interested in something like this? And you're gonna just let me know when we're ready to close out the poll and move on to the next slide.
Yep, I will do that. I'm gonna give it a few more seconds so we can have some more responses.
Okay.
Okay, it looks like the responses have slowed down. Hold on, looks like we're getting a few more actually.
I guess we could leave it up while I go over the learning objectives if that's helpful.
Yeah, absolutely. So we can move to the next slide.
Okay. And these are our learning objectives for today. After our session, everyone should be able to discuss national trends in stimulant use data, review harm reduction efforts for stimulants, identify current prevention and treatment approaches through a public health lens, and identify the impact of methamphetamine and Iowa's strategic efforts to address those impacts. Next slide, please. So our first presenter today is Sheila Vakharia. Sheila is the Deputy Director of the Department of Research and Academic Engagement for the Drug Policy Alliance. In this role, she helps staff and others understand a range of drug policy issues while also responding to new studies with critiques and analysis. She plans conferences and convenings on cutting-edge issues in areas of drugs, drug research, and harm reduction. Additionally, she is responsible for cultivating relationships with researchers from a wide range of disciplines and works to mobilize academics in services of her organization's policy campaigns. So her bio can also be found in the chat box. And today, Sheila will be describing the history of stimulant use across the country and discussing efforts that have developed around harm reduction, prevention, and treatment with a focus on social determinants of health that influence these efforts. And We're very excited to have Sheila present on today's call. And some of the information that Sheila will discuss, and generally some information around the response to stimulant overdoses. And this may not be necessarily OD2A fundable activities, particularly some of those harm reduction methods, but what we're hoping is that this information gives a picture of what that comprehensive response to drug overdoses may look like, and specifically also what partnership opportunities may be out there for OD2A programs. We may not be able to fund some of these activities that are going to be discussed, but there may be an opportunity to partner there or to implement education or linkage to care initiatives. So very interested to see where those opportunities may be. And with that, I will hand it over to Sheila.
Hi, everybody. Thank you so much for having me join you today. And a special thank you to Martha and Risha at ASTO for being my first connections at the organization. So today I'm going to talk about harm reduction for stimulants, what we know works, and what we believe are larger, broader policy changes that need to take place to reduce the harms associated with drug use, and with the caveat that OD2A will not be able to fund a lot of what I'll be talking about, but I can specify some of the things that OD2A could help fund. Next slide. So before I get started, before we talk about overdose, it's really important to first acknowledge just the prevalence of stimulant use. And what I mean by stimulant use are, I'm really talking about 3 specific drugs. I'm talking about prescription stimulants such as Adderall and Ritalin. I'm talking about illicitly manufactured methamphetamine, and I'm talking about cocaine in its various forms. And so as you can see here, this is data from the National Survey on Drug Use and Health. And the most recent data from the NSDA indicates to us that behind marijuana, actually, if you were to combine all stimulant drugs together, they're actually the most commonly used class of illicit substance after marijuana. And unfortunately, this isn't something that has garnered a lot of attention more broadly. And I think one of the challenges of the framing of the current crisis as an opioid crisis is that we ended up really focusing on a single class of drug. And although that class of drug has contributed to a disproportionate number and amount of harms, including death, stimulant use has remained widespread across the United States for some time. And there are parts of the country where opioid use has not really shown the same spikes that we've seen in other parts of the country. And methamphetamine continues to be a challenge in certain parts of the country and also a driver of overdose deaths. Next slide. So before I talk even further about why it is that so many, why it is that we're seeing so many overdose related deaths, I think it's really first important for us to also acknowledge why people use stimulant drugs, right? Motivation is really important, and understanding that people use drugs for reasons is a key part of really understanding how to target prevention, intervention, harm reduction strategies to really help people stay safe and stay alive. So we know that people use stimulants obviously for recreation, but they also use stimulants for a variety of functional and adaptive functions. Motivations for use can include a variety of factors, and they can vary from person to person. But we know that people who use stimulants report that they feel increased energy, euphoria, wakefulness. It helps with focus and attention. It can help with performance enhancement, productivity, increasing confidence. It can be used for self-medication. It can be used to increase sexual desire and longevity, increase pleasure, and increase social acceptance in certain circles. It can also help manage stigma through suppression or through dissociation. It also can help decrease inhibition. It can help with weight loss and appetite suppression. And motivations and benefits for use can often be overlooked when too often we focus only on harms and negative consequences. And we do this a lot in drug treatment, but we also do this a lot in primary care and even in prevention messaging. Failing to understand the motivations can really make it difficult for us to convey messages to stay safer and to really connect with people where they're at. And so by understanding motivations for use, we can better inform harm reduction strategies to reduce risk and maximize benefits for those who intend to continue using stimulants, but it can also help support effective treatment and recovery planning. Yes, caffeine is in this category. However, I'm currently talking about illicit use and use without prescriptions. Next slide. So it's really important for us also to have a really solid theoretical framework when we look at why people use stimulants, why some people continue to use them despite negative consequences, and what function stimulants can serve in people's lives. And there are actually a number of theories that we can lean on to use to understand stimulant use, but other drugs as well. So you can go ahead and click. So one of the first theories that I always want to talk about when I talk about drug use, but also specifically when I talk about stimulant use, is what we call the dislocation theory of addiction, which can be attributed to Canadian researcher Bruce Alexander. And one of the things that he learned in his research, he developed something called Rat Park, and I'm not sure if many of you have heard of this study. Typical studies on drug use and addiction frequently point at neurological changes that happen due to rats that continue to press levers to self-administer drugs, often to the point where they will kill themselves and deprive themselves of food and other things because they want the reinforcement of drug use. Bruce Alexander conducted a very interesting study called Rat Park, in which he created a rat cage scenario, but he also provided rats with partners, playmates, toys, food, a variety of foods, and a variety of things in addition to levers that would administer drugs. And one of the things that he found was that when there was an enriching enough environment and enough of the biopsychosocial needs of these rats were met, because rats are quite social creatures, that oftentimes they weren't drawn as much to the lever to self-administer drugs. And I think this theory is really well illustrated by a quote from Johann Hari, who maybe some of you have read before, in which he says, "The opposite of addiction is not sobriety. The opposite of addiction is social connection." Right? And so when we think about prevention of drug use more broadly or drug-related harms and really helping to keep people safe, zooming out and seeing drug use as a response to challenging social and environmental contexts. Next slide, or next bullet rather. So the next theory, I think, is one that most of us have probably become familiar with through our training, this self-medication hypothesis, which we can attribute to Dr. Kansian, and this idea that some people will continue to use the substance despite negative consequences because it serves some sort of emotional need, whether it can help quell underlying mental health problems or mitigate those experiences, or help to dissociate or manage stress, trauma, or other forms of pain. Next bullet. Another model that we don't often think of enough, but I think is also worth discussing, is just behavioral and reinforcement theories. The understanding that when you pair a substance with the positive experience or an outcome, the positive reinforcement of a drug, that strengthening that relationship between self-administering a substance and the positive reinforcement can be incredibly, activating to a lot of folks. And we have to acknowledge the role that positive reinforcement can play for a lot of folks in continuing to use substances. And that sometimes the positive consequences of using a substance, the alleviation of immediate displeasure, the immediate release or alleviation of stress, oftentimes for some people that proximal benefit can often outweigh the potential distal harms that they may face associated with their drug use. And then lastly, last bullet, obviously biological theories, ideas that there are genetic components that could contribute to some people's vulnerability to use substances problematically, also understanding that neurotransmitter systems are implicated for some people and certain parts of the brain that can create more reinforcing effects of drugs. Next slide. And another thing that we need to think about when we talk about stimulant use is a variety of special populations who we should be considering who are disproportionately likely to experience the harms associated with stimulant use, and those who we should consider in messaging. So now you can just click through some of these bullets for me. So people who experience homelessness increasingly are contributing to a large number of folks who are experiencing harms as well associated with stimulant use. And we know that rising challenges with gentrification and lack of access to housing has continued to drive stimulant use in many communities among many people. But we also need to think about men who have sex with men, particularly in coastal communities and larger cities. This idea that stimulant use, particularly methamphetamine, is prototypically only a rural drug used among white heterosexual communities is a fallacy, and actually the demographics of people who use methamphetamine vary quite broadly. And so thinking about the role that transphobia and heterosexism can play in impacting the effects of stimulant use among men who have sex with men, trans, and cis women. We also have to think about college students and young adults, particularly about the needs of people who inject drugs, people who are currently taking methadone treatment. One thing that we've been hearing increasingly is that folks on methadone treatment have been testing positive for stimulants. So how do we help keep people safe who might be engaging in polysubstance use? And then people who are sex workers or people who sell or trade sex. Next slide. And when we think about these special populations, we have to think about certain considerations. So as I kind of alluded to earlier, the first bullet, social determinants of health are an important factor. Unmet physical needs can drive use, which may be adaptive, right? So homeless, unstably housed, and low-income people who use stimulants have numerous unmet basic physical needs, such as housing, nutrition, and healthcare, which must be integrated into any holistic approach for prevention, harm reduction, or treatment. Stimulant and other drug use, which is often adaptive or a coping mechanism for such circumstances, is unlikely to change without these needs first being met or concurrently being met. And one of the things we need to think about is how stimulant use can often be very helpful with appetite suppression when facing food insecurity or the need to maintain a low weight, but also how stimulants can help mask or manage some of the symptoms of untreated health problems. And greater sensitivity, gender identity, and sexuality is really important because societal transphobia, homophobia, and heterosexism negatively impact men who have sex with men and trans women so that they face disproportionate barriers in access to healthcare treatment, job opportunities, housing, and other supports. In addition, many face stigmatization and isolation from families. Services and policies aimed at people who use stimulants must be attuned to the role of these factors in perpetuating problematic or high-risk use among this community and the intersectional impact of race and class. And last bullet. And we also have to consider that the folks that we're thinking about are part of social networks and social groups, and social norms can influence use. Expectations, pressures, and other positive reinforcement are factors that can contribute to ongoing or high-risk stimulant use in certain groups. So again, zooming in on this as an individual level phenomenon leaves out the variety of social and community level factors that we should be thinking of and targeting as well if we want to reduce the harms of stimulant use. Next. What are some of the risks associated with use? Go ahead, you can go through the bullets. Yep. So heavy or problematic use of stimulants has been associated with acute or chronic cardiovascular problems such as elevated heart rate, blood pressure, chest pain, and heart attack. It has also been linked to increased risk of stroke, increased body temperature, and mental health problems such as hallucinations, paranoia, and anxiety, weight loss, and sleep deprivation. Overamping is a term that's used pretty widely among folks who specialize in stimulant use or people who experience stimulant-related harms. And the reason why we use overamping rather than overdosing is because there is a slightly different phenomenon at play. As I listed just earlier, a lot of the effects associated with stimulant use are cardiovascular and a lot of and also psychological. And so targeting and understanding that someone who might be experiencing crisis due to stimulant use may actually be also experiencing different physiological or psychological effects is really important. And so if we can understand that some people who use high amounts or people who are unexperienced use in ways that make them uncomfortable, we need to also think about how do we help people stay safe if they end up using too much. What we also know, go back, yeah, thank you, is that people who inject stimulants are at risk for bloodborne infections such as HIV and hepatitis C, just as opioid users in terms of sharing syringes and equipment. But we also have to think about the increased risk of wounds and bacterial infections if precautions aren't taken and if their injection sites are not properly cleaned. And we also have to remember that injection frequency may look different for stimulants versus opioids. And so the sterile syringe equipment needs may look different compared to opioids. So whereas most heroin users will report a pretty consistent, regular injection pattern, stimulant users may not. And we also have to think about sexually transmitted infections. We know that stimulants are really great for sex. They make sex more pleasurable. They make it so that you can last longer. And they can also help suppress internalized feelings of homophobia and transphobia if you're engaging in sexual activity and you've got some of that, some of those factors contributing to how you feel about yourself as a sexual being. And so talking about safer sex practices is really, really important. And we know this with queer communities, but we also know this with straight communities. And we know that women who use stimulants also are at risk for increased sexually transmitted infections. And so how do we help them stay safe? All right, next slide. So one of the things that came up with the recent overdose data that we just received from the CDC is that we found out that overdose deaths slightly increased by about 5% nationally last year. And another alarming trend that emerged was that we actually found that on a national scale, cocaine and methamphetamine overdoses actually continued to increase, and more overdose deaths across the country involved cocaine or methamphetamine than involved heroin or prescription opioids. And on a national scale, this should bring some cause for concern. Fentanyl continues to drive the overdose crisis. So in this graph, you can see the black line is the aggregate line of overdose deaths. That brown line is fentanyl, and the pink line is cocaine, and the gray line is methamphetamine. And below them, the blue and green lines are heroin and prescription opioids. So again, calling this an opioid crisis increasingly is being revealed as an overly simplistic narrative, one that overlooks the fact that stimulants are involved in overdose, but also that polysubstance use is driving a lot of overdose deaths. Next slide. And we also need to look at regional variation. So here are two states in the West in which I just kind of threw the circle over it, where you can see that methamphetamine involved overdose deaths are actually driving overdose deaths in a lot of our Western states. And so opioid specific messaging may not feel relevant or entirely accurate to the experiences that people on the ground are facing. Next slide. Meanwhile, when we look at states to the east, we can see that cocaine involved overdose deaths are now starting to play an increasing role. Again, warranting cause for concern, but also complicating the broader opioid-centric narrative. Next slide. And what's interesting is that if we look at the Midwest, we actually kind of see more of a complicated and mixed picture. Some states in the Midwest being more similar or representative of Eastern drug use trends versus some states being more reflective of Western drug use trends. And a lot of this can be due to the fact that Midwestern states are often hubs for drug supply chains and networks. And so the direction that the drug supply might be moving in could be indicative of what kind of trends you might see in a different state. Next slide. And so what do we mean when we talk about harm reduction interventions for stimulants? You can go ahead and click. Obviously, we have to think about safer equipment, right? And when we think about safer stimulant use, we have to acknowledge that smoking and snorting are very commonly used routes of administration. And so how do we help keep people safe who may be using those routes of administration? And how might harm reduction messaging help people to switch if that is helpful? We also know that drug checking equipment such as fentanyl test strips are increasingly going to be necessary for people who use stimulants, as reports that adulterated stimulant supplies are increasingly emerging in certain communities. This is not an incredibly widespread phenomenon, but we know that it is happening and that it exists. And so how do we help people stay safe? Also by providing naloxone, right? And that in the next bullet, that kind of addresses some of the social determinants of health, right? So as I said to you before, if we know that appetite suppression and staying up for a long period of time are factors associated with methamphetamine use, how do we help people make sure that they're staying hydrated and fed? How do we help them learn de-escalation strategies if they find themselves feeling amped up or overstimulated? And other societal and social, determinants of health and strategies for sexual risk reduction. And next bullet. Obviously, the CDC does not endorse this statement, but safer consumption spaces, an intervention that is one that my organization is advocating for, places where people can bring pre-obtained drugs and administer drugs under supervision are a key place where we believe that drug-related harms and stimulant-related harms can be reduced. So I have a list from OD2A talking about some of the strategies that some of your funds can help support. So I'll tell you a little bit about them. So Naloxone distribution is something that you can work on, as well as supporting medication-assisted treatment and public education. Other activities that you can fund with some of this money might be specific activities around addressing stigma for overdose, seeking help, administering naloxone. We also know that you can use this money to deliver targeted messaging for people who use drugs about the presence of fentanyl in their drug supply. We also know that you can mobilize your own networks and communities. So if there are syringe exchange programs or other types of programs in your communities doing this work, you can collaborate with them and uplift their work, and also help conduct research on their outcomes and demonstrate those outcomes through evaluations that can then be used to promote interventions that are proven to work in your community. So these are just some examples that I was given from OD2A. Next slide. Although we don't have evidence, although we don't have FDA-approved medications for stimulant use disorders yet, there have been some systematic reviews that suggest that certain medications could be used on an off-label basis. But I don't have time to go into that just yet, and I'm just going to try to push through my next slide. And I will wrap up on this last slide. So you can go ahead and click through some of these bullets. So one of the challenges that we have to remember is that the behaviors associated with people under the influence of crack cocaine or methamphetamine, such as rapid speech, sexuality, violence, agitation, jitteriness, and skin picking, can amplify the stigma associated with stimulant use, but also serve to stigmatize those communities. So it makes them visible targets for judgment and scorn, for additional policing, and for additional, stigma from the community. So how do we, as public health experts, really not affirm these stigmatizing myths in our prevention messaging, but how do we also target, address that specific stigma to actually show that these are communities worthy and deserving of help, who should come out of the shadows to come seek services. Another challenge that we need to acknowledge is that a lot of our messaging around public health and harm reduction was built around an opioid-centric playbook. So having to think outside the box to address stimulant use and stimulant-related harm is really important. And then despite the fact that, as I said before, stimulant use is so widespread, there's so much stigma and there's so much mischaracterization of who uses stimulants and why they use them, that we really need to challenge those myths, and we need to really acknowledge how widespread these substances are. We also have to acknowledge that polysubstance use is going to continue to increase the risk associated with stimulant use, and that our messaging needs to acknowledge that people are sometimes using multiple classes of drugs. And that an adulterated drug supply isn't just happening in our opioid supply, but in our stimulant supply. And we should commit to doing increased research on what works and how to help, and that criminalization can create and perpetuate new harms. So I'm going to stop at that point, and maybe I can get to some of the things on my next bullet during the Q&A.
Thank you so much, Sheila. I can now introduce our next presenters, Michelle Tilotta and Katie B. Michelle Tilotta serves as the Substance Abuse Treatment and Prevention Block Grant and Seminar Manager at the Iowa Department of Health, and is a registered nurse with over 35 years of experience in nursing, including medical and behavioral health, quality improvement, managed care, and public health experience. Katie B. serves as a community health and prevention consultant for the Bureau of Substance Abuse at the Iowa Department of Health. Her background in prevention includes department management, extensive community mobilization, knowledge of best practices in prevention, and campaign development. She has spoken on the benefits of community-based prevention at various conferences, and their bios can both also be found in the chat box. And with that, I will turn it over to Katie or Michelle.
Hi, good afternoon. This is Michelle Tilotta, and I'm with the Iowa Department of Public Health. Katie and I will be shifting focus a bit and focusing on Iowa's strategic plan to address methamphetamine in Iowa, which is a significant rising concern in Iowa. The Iowa Department of Public Health is the single state authority for substance abuse, and we are the administrators of the Substance Abuse Block Grant funding. We are very intentional about assessing capacity, knowledge, and resources And we have specifically several years back started a strategic plan because methamphetamine was significantly rising in our state. Back in 2005, 2007, methamphetamine was significantly decreasing. And then in the last couple of years, we're seeing substance abuse treatment rates for our adult populations at about 24%. Which is a significant sharp incline. So we've been very focused and very intentional about looking at our capacity, looking at our resources, what can we do to address this rising concern in Iowa, and engaging the full spectrum of our levels of care as our providers with our different levels of care, and everything from early intervention in the prevention side all the way through treatment on our treatment side. So public health at the Department of Public Health, the Division of Behavioral Health, I know we have lots of different acronyms, and in the Bureau of Substance Abuse is where our prevention and our treatment sit. So just that you have a picture of that. Next slide, please. Today, we just want to have a brief overview of our current prevention and treatment approaches that are available to Iowans through that public health lens, which I think is extremely critical. Sheila was talking in her presentation, really normalizing our approaches and having non-stigma approaches is central and key to the work that we do. And really identifying the impact methamphetamine has on Iowans and all of our strategic prevention efforts to protect and improve the health of Iowans. Next slide, please. Just as a brief demographic, so that if you're not familiar with Iowa, and then this census does have U.S. Census 2017. But I just checked this, and it's roughly around the same. Our population is 3 million, and we have 64% of our population is set in urban settings, while 35% is in rural settings. And then, you know, our population is mostly centered in that urban population. We're a very agricultural state. We have a very aging state. So we share a lot of the same kinds of complex issues and barriers that you all share as far as rural communities, workforce development, educating our workforce to be competent. So just wanted to give you a breakdown of what you see in our population as well. We're about 90% Caucasian white, 5.7% Hispanic Latino, 3.6% African American or Black, 2.4% Asian, and 0.3% Native Hawaiian or Pacific Islander. Next slide, please. Iowa's public health approach really began with a statewide focus and priority of our department director, Director Gerd Kleibau. Several years ago, a lot of different stakeholders, partners, organizations around our state were bringing to his attention the increase in methamphetamine use that all of our providers were learning about, hearing about. And we, as the Department of Public Health, are accredited by the Public Health, National Public Health Governing for Quality Improvement. And we went through public health accreditation, and through that there are multiple standards. But one of the things that there's a policy white paper out that's called Public Health 3.0, and in that document, it talks a lot about what a public health department should look like and what kinds of roles they should be taking. And within this lens, they identified a chief health strategist. And as the state's chief health strategist, we are the chief health strategist for population health. And we really rely on expertise and take leadership on several different areas. We want to rely on expertise of others, but also be the go-to department for helping support others, helping collaborate with others, and leading data. We want to make sure our data is quality data that we do share with others. We want to make sure that we see and we lead based on a health equity lens. We want to be really thoughtful on our strategy and very targeted in our interventions. We also take the role on policy development, planning initiatives, performance measurement, quality improvement activities, and really take the lead on training and looking at that workforce that we have. Public health policy really does include that research, development, implementation, and evaluation of healthcare policies and initiatives that impact the health of Iowans. And with all that said, you all are familiar with your public health in your state through the COVID epidemic, and it's really being that person out there that has that expertise, but is also the collaborator with other agencies that need to be. As I discussed, we are the single state authority for substance abuse through the Department of Public Health, the Division of Behavioral Health, and that is the policy on substance use disorder. Our mental health department is at a separate state department. We do significantly collaborate with them for any type of co-occurring mental health or substance use disorders. We also, during our strategic planning, as I discussed, we look at a variety of different health promotion initiatives, prevention and treatment approaches, and make sure that everything that we do is based on data and is from a data-driven process. Next slide, please. Methamphetamine, this is a little bit of some data that I wanted to share with you. Methamphetamine seizures by our Iowa law enforcement agencies have dropped off following substantial reductions 10 years ago, and as I discussed earlier, risen in recent years. We know that a lot of the methamphetamine that's out there in the communities, and some of that reason is because the prices have significantly dropped and the purity of methamphetamine is a lot more potent. 99 to 100% pure compared to 14 to 40% purity from 10 years ago, and that's what's coming into our state currently. In 2005, we also had the pseudoephedrine legislation changes where there was not the availability of pseudoephedrine, and many of your states may have some of this, but all pharmacies that sell non-prescription pseudoephedrine, must sign out at the pharmacy counter for those. Prescriptions such as like Sudafed and things that you all might be familiar with when you go and pick up a over-the-counter medication that has that in there. Next slide, please. From 2014 to 2018, the rate of methamphetamine-related treatment admissions really increased at 50% in our state. I want to get my turn my slide so I can read this. I have faces, sorry. So rates from 2014 to 2018, men are 54% and women at 46% were admitted at different but increasing rates for methamphetamine treatment. And what that means is that women, we are seeing our special populations, as Sheila was talking a little bit about special pops, we see in our state very similar things to what Sheila mentioned, but also we see the #1 treatment admission for women that admitted to treatment services has a primary or secondary diagnosis of methamphetamine. In 2018, Iowans enter substance use disorder treatment with meth as the primary substance abuse at an all-time high. Next slide, please. In 2018, Iowans aged 25 to 44 had the highest rates of methamphetamine-related treatment admissions compared to other groups. When we look at ages below that, we don't see a significant and almost a 0% use in methamphetamine with our youth. And this is something that we always try to point out, is that from the time up until through to age 24, we see such a small number of methamphetamine related treatment admissions. And then from 25 to 44, it significantly increases. And that is such a valuable opportunity at that point to do some significant prevention work before they hit that 25-year age. And you can see in some of our data, which still holds true for women, and the methamphetamines has actually jumped up. We're seeing methamphetamine now rising above marijuana, alcohol, and opioids. Next slide, please. In some of our linkages to care work that we are doing, what I did on this slide was just try to put together some of the activities and strategies that the Department of Public Health is really very strategic and focused on. As many of you probably have multiple different grant opportunities or different grants that you might have, or that you work with different partners that have different grants or priorities. So as we do, and sometimes it's a real, we've made it a strategic initiative to really look at all of the grants that we apply for, and what work are we doing in each of those grants, and what opportunities in each of those grants do we have an ability to be able to share our resources, look at our stakeholders that are involved, what activities or recovery support services or things that folks can purchase be in each of these different grants. So our Overdose Data to Action grant, are promoting integration of primary and behavioral health in our Iowa State Opioid Targeted Response grants. You know, although some similarities exist in how opportunities are written and strategies are implemented, what is it that we can do so that we can really leverage, sustain, and coordinate between all of them, so there's not a duplication of work that our contractors are doing or services that we're rolling out to Iowans. Overdose Data to Action in our year 2 strategy, we're really looking at how do we collect data in a data collection system. We are looking at developing that. We're very focused on what does our data show. Through the Department of Public Health, we have a policy on health equity and on how we look at and administer and provide data. So what are those opportunities from the department that we can promote that health disparities, reducing health disparities, and looking at how do we create and annually evaluate standards for collection of data that will inform health determinants of health and the health equity through the department. How do we look at standardizing demographic variables and other data that we want to collect? And how do we really create those standards for analysis of data so that we can evaluate the determinants of health and health equity throughout the entire department? So OD2A will be looking at data collection systems, and also they will be focusing on development in year 2, development of that linkage to care advisory group, where they will be looking at piloting a linkage collaboration with the state opioid response grant. So that's like one example of how we try to look at different grant opportunities. And we also, when I have this division liaison position between HIV and behavioral health, our Bureau of HIV, STD, and hepatitis sit within our Department of Public Health in our division, which is really an amazing opportunity to be able to collaborate back and forth between our bureaus and create strategies and policies that are not duplicative And that one of the nice things that we did recently was we hired a liaison that actually works between our two bureaus. So we can look at educating and piloting work between our STD work, our Hep C work, and our HIV testing. And we can look at how can we pilot that, and how can we be intentional on bringing that work into our substance use disorder contractors. And so really trying to look at the work between our substance abuse and our HIV, and reducing any kind of health disparities there that we can. Next slide, please. Resources and strategies. Okay. And Katie, I think that I will turn this over to you and let you finish it up. Katie B. from the Iowa Department of Public Health.
Thank you, Michelle, for that introduction. And I too will thank Rashika Desai for reaching out to both Michelle and myself to invite us to today's presentation. So I get the opportunity to kind of wrap up today's webinar for everyone on the call. And really, we have about 10 minutes left. So kind of to wrap up, we're really going to be focusing on Iowa's resources and strategies. So based on the content that Michelle just shared, we want to give a high-level overview of specific efforts that have taken place since March of 2018 to address specifically methamphetamine use in the state of Iowa. So next slide, please. So as Michelle has mentioned, in this early spring of 2018, we really had this impetus by looking at our data and identified from the Iowa Department of Public Health leadership that we wanted to develop a methamphetamine work group that was going to be hyper-focused on looking at the current state of methamphetamine use in the state. And early on in the development of that methamphetamine work group, one of the big undertakings that the members did was they developed a strategic plan to guide efforts, at least for the first year of the work group, so that we were all kind of oaring in the right direction, if you will, when it came to addressing methamphetamine. So this is just a broad overview of what was listed within that strategic plan. But again, we were very intentional about the items to be included within that plan to guide future efforts. So talking about capacity building, and as it aligns to OD 2A's linkages to care, we really wanted to make sure that we had the right people at the table. And this is a work in progress. We're continuing to continually revisit capacity for the methamphetamine work group. We're continually looking at who are new partners to engage that maybe we haven't engaged at this current point in time. Going back to what Michelle was mentioning earlier about being intentional of not duplicating efforts to address methamphetamine as well as other substances in the state. So during those very early stages, what we did is we identified state partners, prevention and treatment providers, and medical providers that were really hyper-focused on this subject, and then also having conversations with those partners to identify what they were doing to address the topic of methamphetamine. In addition to that bullet point, we also were very intentional about how the other strategic plan items were going to be woven into who those partners were. We wanted to make sure that any efforts that were initiated or collaborated with on behalf of the work group also reached these individuals and met their needs as they navigated these waters as well. We also focused on education to Iowans, and in order to do that, we really wanted to be looking at the data-driven process. We wanted to look at what the needs were in the state of Iowa, and then develop media outlets to speak to those data as well. So what we ended up doing that first initial year is we developed 2 radio ads that ran throughout the state of Iowa on multiple radio wavelengths. And one of those radio ads was specific to the general population, but really talked about how to access treatment if the need arose. And then we also had a radio ad that was specific to women. And based on the data that we were looking at, this specific radio ad was focused on women of childbearing age and women that that may be pregnant, and again, encouraging those to seek treatment if and when they were ready. In addition, we included an updated infographic that was made available that kind of wove both state as well as national data together, as well as some social media panels that our IDPH funded providers could utilize at their discretion. Speaking into that third bullet point of looking at the infographic and data briefs, not only did we do the infographic and the social media panels, which we'll show you a little bit later in today's presentation, but we also updated some data briefs that looked at 5 data sets. And we had a June 2018 data brief as well as an October 2019 data brief that was made available to anyone interested in the topic. Those were shared with the Iowa Department of Public Health Bureau of Substance Abuse contracted agencies, and they could provide those information awareness resources to their community partners at their discretion. Another key central point of focus for the work group was that analysis of the data, really making sure that the strategic plan was based on the local data that we have available to us, not only again at the local level, but at the state level as well, and making sure that within those conversations of looking at the data, analyzing the data, that we're also talking about health equity strategies as appropriate. Next slide, please. In addition, these are some additional items that were included in the strategic plan. So we wanted to be very cognizant of having ongoing stakeholder meetings, task force meetings or advisory meetings, and again, engaging other key stakeholders throughout the state who may be having these types of conversations as well. We were very much aware that the methamphetamine work group that was developed for the Iowa Department of Public Health was one stakeholder group. And we realized that there were many other individuals and many other groups in the state of Iowa that were addressing methamphetamine. So we are identifying who those individuals are, those stakeholders are, and engaging them in conversations as we move forward. One of the data tools that we use through the Iowa Department of Public Health is the Community Assessment Workbook. And through our prevention services, and this also aligns with this last bullet point, through our block grant funded providers through the Substance Abuse Mental Health Services Administration, we're having those providers use the strategic prevention framework to guide primary prevention services. And one of the deliverables that they will be utilizing this upcoming year is a community assessment workbook to really get down to the granular level within their counties of how substance misuse is impacting all 99 counties within the state of Iowa. And methamphetamine is included within those community assessment workbooks. So throughout this next contract year, we will have some really rich data to identify how methamphetamine is or is not impacting certain areas of the state, and that's kind of to be determined. We also were kind of pivotal in the statewide conferences and making sure that we were bringing in individuals that could speak to best practices and current practices when it came to methamphetamine as well as stimulants. We had in December of 2019 an event called a public health approach. We had an event called A Closer Look, Methamphetamine, Opioids, and Polysubstance Use. And that event was very well received, and it goes back to what Sheila was saying. It was broader than just an opioid conversation, but also brought in the topic of stimulants and methamphetamine as well. In addition, each year, the Iowa Department of Public Health holds the Iowa Governor's Conference on Substance Abuse, and work group members, as well as my colleagues within the Bureau of Substance Abuse, we definitely make sure that we are providing names of individuals that are talking about methamphetamine, that are talking about stimulants, and reaching out to them to see if they'd be interested in speaking on the topic during those annual conferences. Michelle, do you want to speak briefly about the Project ECHO training?
So we also utilize Project ECHO, and some of you may be familiar with it. It stands for Extension for Community Healthcare Outcomes. And it's just very much a model of delivery and health education, similar to a hub and spoke type of model. So there's some education, there's usually a general a practice or an expert that's on one end that's joined by other community members. And we rolled this out to our women and children providers and focused a series of 6 sessions on methamphetamine related to women so that they could have knowledge and learn from healthcare experts.
Thank you, Michelle. Next slide, please. So over the next few slides, we're going to show you some of the prevention resources that were developed, again, since March of 2018. Next slide, please. So this is a visual of that methamphetamine data brief that I had briefly mentioned. Again, the first iteration was June of 2018, with the second iteration being October of 2019. And within this data brief, we really highlighted methamphetamine-related treatment admissions, methamphetamine use by Iowans, youth perception of risk, youth access to methamphetamine, labs seized and production of methamphetamine in the presence of a minor, as well as amphetamine-related emergency department visits and hospitalizations, and lastly, methamphetamine-related deaths. Next slide, please. So this is a picture of the infographic that was developed back in early spring of 2018. So this very first infographic was provided to the IDPH funded contractors, and that very first up on the upper right hand corner where you see from 2014 to 2017, there was a 38% increase in methamphetamine treatment admissions in Iowa. And again, that really was what led us to be developing a methamphetamine work group and really start looking a little bit closer at how methamphetamine is impacting Iowans and the various ways that we could address that across the continuum. So what we had is with this infographic, it was the 1-page infographic, which was an 8.5 by 11 sheet. But then we also had these social media slides. So each of the boxes, if you will, within the infographic were also standalone social media posts so that individuals, if they wanted to raise awareness about the need in Iowa based on the data, they could simply use those slides on their social media accounts. Next slide, please. Also wanted to talk briefly about Your Life Iowa. So Your Life Iowa, I would encourage anyone who's interested in learning more about it to simply visit Your Life Iowa on Google. This is the single statewide 24-hour crisis line. So this is 24/7, 365 days a year. And Your Life Iowa provides website and online chat. There's a call center that also includes 1-800-BETS-OFF, and that's for gambling treatment services. And there's also a texting opportunity. So at the time when this initially was developed, there was collaborative conversations taking place to include mental health within Your Life Iowa. And I'm happy to report that there has been a refresh of the Your Life Iowa page. So it will look a little bit different if and when you visit it, but it now does include mental health in addition to alcohol, drugs, suicide, gambling, and tobacco. Next slide, please. So this is one of the pages on Your Life Iowa that I thought would be beneficial to OD2A recipients. And this is a prevention training tab that we have. So when you visit Your Life Iowa and you go to the top ribbon, you'll see prevention. And if you scroll down, you'll actually click on training. So our prevention team within the Bureau of Substance Abuse holds monthly prevention webinars. And those are the first Friday of the month from 1 to 2:30 p.m. And really they're broad topics that would be beneficial to anyone interested in learning about the topic. What you'll find, and it's not on this screen, but I wanted to raise awareness of it, is if you visit this page on alcohol or under the alcohol and other drugs section, you'll find a recording for a public health approach to addressing methamphetamine in Iowa. And there you'll actually listen to Michelle Tilotta and myself, and we go over about an hour and a half worth of content. You kind of got the Cliff's Notes version today, but if you want to learn more about our approach in Iowa, you could always visit that recording to learn more. Next slide, please. And then lastly, wanted to talk just briefly about the methamphetamine page. So again, wanted to make sure that our prevention network had the resources available to understand kind of at a high level of what methamphetamine is. And then we continue to add resources to that bottom section so that individuals have the information they need or are just interested in when it comes to methamphetamine. Next slide, please. So with that, I will pass it back over to Jen, and she will address any questions that may have come through with the chat. Thank you.
Thank you so much to Michelle and Katie and Sheila. Unfortunately, we're right at time, so we don't have time to do live questions. If anyone does have questions, Sheila, I know you said you're willing and able to connect over email. Katie and Michelle, are you available to connect in the same avenue as well?
Yes.
Absolutely.
Yep.
Okay. You can either send questions to us now in the chat and we can connect those with the presenters, or you can email the presenters. Katie and Michelle's emails are listed here on the slide, and I know Sheila put hers into the chat box. So thank you very much again to all of our presenters. And Yorana, if we could just go to the evaluation slide. And I'm seeing questions about, can we get slides? I believe that the slides can be sent out. I will double check with all of the presenters, and Sheila's saying yes, and we will send them out to you if possible. We would really appreciate everyone's thoughts on the session today. The evaluation link is in the chat. You can click it there and tell us what you thought. Thank you again to everyone for joining us, and I hope everyone has a great day. Bye all.
Thank you.
Thank you.
Thank you.